Hello, everyone. Thank you again for joining us today for the last episode of our POCUS monthly lecture series of 2024. For those who are new here, POCUS stands for POCUS for Emergency and Acute Care in Resource-Limited Settings, and we're a non-profit organization entirely run by volunteers, and we aim to provide free POCUS training to doctors around the world. And it's my great pleasure today to have Dr. McLean, an intensivist currently based in Newcastle, Australia. He is also one of our lead faculty members who has led many in-person workshops in multiple countries in the Pacific Island region. He has a special interest in echo and been further trained in ECMO. Today, he will be presenting on the use of POCUS in rheumatic heart disease. And due to some issues with internet connection, Louis has actually pre-recorded this lecture earlier today, which I will play shortly. However, he's also online, and he will be able to answer any of your questions in the chat box. And we will also leave 10 to 15 minutes at the end of this time slot for Q&A. And you can unmute yourself and ask Louis directly as well. So without further ado, I will start the lecture now.
Hi, and welcome to Pearl's Rheumatic Heart Disease. Today we're going to talk about mitral stenosis and the management of mitral stenosis, specifically using the skills that are learned through the Pearl's critical care course. My name is McLean. I'm an intensive care specialist, and I'm one of the conveners of the Pearl's critical care course. Over the next few months, we're going to have a number of talks on rheumatic heart disease, which I'm really looking forward to, including a talk by Professor Julian Wally. Julian, I'm sorry if I got your name. One of the foremost experts in Australasia. There's going to be talks on diagnosis and management and the intersectionality of two, specifically based on the data that you can gather from the skills you will learn in the Pearl's critical care course. So just a reminder that Pearl's consists of the Pearl's ED course and the Pearl's critical care course, with the Pearl's critical care course focusing on basic critical care echocardiography as well as lung ultrasound. It's really important before we go any further to recognise the importance of antibiotic treatment for slowing or arresting disease progression in rheumatic heart disease. And I would recommend that you refer to your local guidelines. There's a lot of manifestations from a cardiac point of view, and rheumatic heart disease has a spectrum of carditis, early on in the disease process, following an acute rheumatic fever, to mitral valve disease, either stenosis or regurgitation, or both, aortic valve disease, stenosis or regurgitation, or both, and much less frequently, tricuspid and pulmonary valve disease. Mitral valve disease is the most common, and the aortic valve less so, with the mitral valve usually affected if the other valves are as well. Recognizing that congenital disease of valves can also occur, which can predispose to rheumatic disease progression. We're going to talk about rheumatic mitral stenosis in this talk. I really want to emphasize that this talk is going to be using all of the skills taught in Pearl's critical care, using 2D, M-mode and Doppler, but that we recommend further assessment using comprehensive echocardiography and specifically using advanced Doppler such as pulse wave and continuous wave to fully assess the severity of disease and possible interventions. The staging of rheumatic heart disease from stage A to stage D is based on a progression of disease, with borderline rheumatic heart disease being diagnosed when you have an early echocardiographic criteria. Definite rheumatic heart disease is seen with advanced disease, as well as with stage B, where you've normally got some features of rheumatic heart disease, such as a diastolic doming of the mitral valve, but without necessarily high gradients or features that would result in symptoms. What we're not talking about is normal heart valves. We're not talking about diagnosis in this talk. Just one more mention of the aortic valve, and really what I'd like to draw your attention on is here the doming of the aortic valve, which represents the commissural fusion, which is a common final pathway in terms of pathophysiology with the mitral valve and the aortic valve. Commissural fusion of the aortic valve, commissural fusion of the mitral valve, both result in stenotic lesions, but the coaptation defects that occur in both valves can also result in regurgitant lesions. Specifically, the commissural fusion affects the aortic valve in systole, whereas it affects the mitral valve in diastole, as we'll talk about a little bit more in the talk. Here you can see the mitral valve, which has the characteristic diastolic doming appearance with enlarged left atrium, but also the aortic valve affected with commissural fusion. So in mitral stenosis, we know that a normal valve area is more than 4 centimeters. Symptoms begin to appear once you get below about 2 centimeters. And critical stenosis, which has significant flow-on effects, occurs below 1 centimeter. And your risk of death with this disease progresses as your valve area decreases. Usually in the parasternal long axis view, we'll look for the diastolic doming, which we'll talk about in a second. And that's reduced mobility of the valve tips compared to the base of the leaflets. Posterior mitral valve leaflets usually restricted as well. The parasternal short axis, which you can see here, you can see the leaflet thickening and the commissural fusion, which is the characteristic hallmark of the disease. You can also perform planimetry, which has been performed here, and demonstrate the cross-sectional area of the valve. It's really important when you do this to scan all the way through the valve and to find the smallest orifice and to be sure that you're directly at the tips. Very easy to get this measurement wrong. When performed well in parasternal short axis using surface echo, can be quite accurate, but it's also easy to get it wrong. Modified long axis and apical 4-chamber views are used to look for regurgitation and also to well visualize the chordae and the abnormalities that can occur there. And then the consequences of mitral stenosis on the other cardiac chambers, such as left atrial dilatation, tricuspid regurgitation, and right ventricular function, should also be evaluated. In Australia, degenerative is far more common than rheumatic congenital disease causing mitral stenosis. However, in low resource settings, such as Solomon Islands, for example, rheumatic disease is much more common than congenital, than degenerative. So we're going to talk now a little bit about the characteristic changes of rheumatic disease. Commissural fusion. So fusion at the commissures results in a narrowing of the valve orifice. Leaflet thickening then occurs, especially at the free edges. And then finally, sometimes not finally, at the same time, perhaps even slightly prior to, shortening and fusion of the chordae can occur. The abnormal chordae and the leaflet thickening are characteristic of mitral stenosis due to rheumatic heart disease, and they are responsible for the diastolic doming hockey stick appearance. that you usually see in mitral stenosis due to rheumatic heart disease. We are used to looking at some of the things that we look for in mitral stenosis on other modalities, such as chest X-ray. And here I'll just point out that features such as an enlarged left atrium, large right atrial border, enlarged right ventricle, these are features that we've been taught to assess in, for example, chest X-ray as features consistent with rheumatic mitral stenosis. And what we're going to be doing is looking for those features using basic critical care echocardiography. Just like to make note of the finding on this X-ray, which demonstrates that the left main bronchus has been pushed up by left atrial enlargement. All right, if you're doing a comprehensive echocardiogram, these are the things that you would look for in order to determine severe mitral stenosis. You've got planimetry of the valve, less than 1 centimeter, pressure half time, which is a Doppler measurement, mean gradient, again, Doppler measurement, PASP, which is a Doppler measurement through a tricuspid regurgitative jet in most situations. And then other measures, other consequences, such as left atrial pressure, left atrial size, and the Wilkins score, which we'll talk about in a little bit. Again, planimetry can be useful, but it's subject to many caveats. And you do need to make sure that it correlates with the clinical findings. Here you can see that we've measured the mitral valve area at 1.72 centimeters squared, so less than 2. So this patient was likely to be symptomatic. Obviously, the increases in transmitral flow, such as conditions such as pregnancy and sepsis, can accentuate the small valve area and more likely to cause symptoms. You can use the ellipse tool in the butterfly platform in order to measure a mitral valve planimetry. However, this is not as accurate as tracing it, and I don't recommend it. Just quickly from a historical point of view, I'd like to just mention the M-mode measurement or the M-mode characteristic of mitral stenosis. And once you've seen this, you'll always remember it. In the PELS critical care course, we do encourage people to put an M-mode through the mitral valve leaflet tip in order to assess for the E-point septal separation. If you are doing that, you will find a feature known as the loss of the EF slope. So the EF slope is the usual drop in the position of the anterior mitral valve leaflet as the filling stage of diastole and prepares for the atrial kick. So normally there's 2 bumps, which you can see here. Early filling, atrial kick, they represent a normal diastolic filling period. But in mitral stenosis, you can see that there is no EF slope and that this very tight valve remains open as best it can, empty. back the other way, and it goes back into the pulmonary veins. The pulmonary veins are low pressure vessels that, as the left atrial pressure increases, become more and more pressurized and engorged. This is the fundamental problem that leads to the subsequent downstream effects. We are pretty used to looking at pulmonary capillary wedge pressure when we think about chest x-rays. Again, just relating this back to what we know. Early work looking at cardiac failure and progressive chest x-ray changes over time showed that pulmonary capillary wedge pressure of 13 to 18 resulted in hollow diversion of the vessels. 19 to 25 resulted in curly B lines representing interstitial edema. And then a pulmonary capillary wedge pressure, or a left atrial pressure of greater than 25, results in the bat wing appearance of alveolar edema. This is really useful from a echocardiographic point of view because it helps us define the disease. And as we've already said, the mitral stenosis, the main principal effect is the back pressure on the pulmonary veins, resulting in pulmonary venous congestion. And that elevated left atrial pressure, otherwise known as the pulmonary capillary wedge pressure, is transmitted back to the pulmonary parenchyma. So what sort of problem have we got? We've got here a couple of schematics showing normal right ventricular systolic pressure, so pressures, normal LV filling pressures. The pulmonary vasculature is a low pressure circuit. Blood egresses through there under low pressure, transferring from the right ventricle to the left atrium. We are not talking about pulmonary artery hypertension, where you've got an increased pulmonary vascular pressure. We're talking about increased left atrial pressure. We're talking about increased left atrial pressure that is elevated in a prolonged fashion, eventually results in an elevated pulmonary vascular resistance, partly through remodeling. So this pulmonary venous hypertension causes remodeling over time, particularly if it's been present severe for years. Every good talk should have a Netter diagram in it, and this is no exception. This is a slide just to remind us of the other issues that can come with the left atrial pressure. So you will have left atrial pressure elevation, you will have enlargement of the left atrium, you will have slow flow and thrombosis, you will have atrial fibrillation, you will have a diminished left ventricular filling. It's really important to remember that a stenotic lesion represents fixed cardiac output, particularly when it's severe. And that fixed cardiac output can be accentuated in states such as pregnancy, disease states such as sepsis, where a tight mitral valve will become unmasked. Pulmonary congestion, edema, elevated wedge pressure, hemoptysis, these are all part of the pathophysiology of this disease. The pulmonary hypertension results in elevated venous pressures, portal hypertension, and liver dysfunction. Okay, let's do a case. 30-year-old female, short of breath, hypoxic, SATs of 84%, on room air, progressive dyspnea over the past 6 months. I want to emphasize that this case was performed by one of our PERLS critical care participants, and it's an example of what you can do with basic critical care echocardiography without moving into advanced critical care echocardiography. You can make important inroads in gathering information that helps you manage your patient. Okay, here you can see typical appearance with diastolic doming or hockey sticking of mitral stenosis in rheumatic heart disease. The appearance of the mitral valve, particularly at the tips, it's very thickened and probably calcified. One gets the sense that the subcaudal or caudal structures, subvalvular structures are affected as well. The left atrium is large, particularly in comparison to the aortic root. The aortic valve appears okay. The right ventricle appears enlarged, again, in relationship to the aortic root. And there's a double bounce of the septum that is quite concerning. So what we've got here is diastolic doming, thickening of the mitral valve. What we really want to do, and what this clinician did not do, is to assess the mitral valve with colour. We do that because mixed lesions, regurgitant and stenotic, there's an aortic valve level parasternal axis. And again here, there's a number of interesting findings. We can see the right atrium appears significantly enlarged. Again, the aortic valve appears thin and pliable without the evidence of the commissural effusion. This structure here is left atrium, and right here is the interatrial septum, which has a fixed curvature towards the right atrium. This means that the left atrial pressure is higher than the right atrial pressure, whatever that may be. Sometimes, and it's not well demonstrated here, sometimes you can get a sense of what the radial contraction of the right ventricle is and how much the right ventricle is moving in. I wouldn't overassess that. The important thing here is that you can see the left atrial pressure is higher than the right atrial pressure, whatever that may be. Estimating left atrial pressure is difficult, even for experts. Estimating right atrial pressure is a lot more accessible. This is the parasternal short axis at the level of the mitral valve. And this is not a perfect view. This is somewhat off axis. We can see that that beautiful planimetry is not really going to be accessible to us because it's off axis. But you can certainly see that this subvalvular structure here is very, very thickened. The commissure, particularly at this end, is thickened, fused. We can see the right ventricle compared to the left ventricle. Right ventricular chamber, much larger than the left ventricle. And we can see that double bounce again that represents a interventricular septum that's moving abnormally. And in particular, you can see a D-shaped septum pretty much throughout the cardiac cycle. So probably representative of pressure and volume overload of the right ventricle. So mitral valve thickening, commissural effusion with a small mitral valve area, even though it's not measured. Coming down to the mid-papillary view, roughly, again, you can see thickening of the subvalvular apparatus and the abnormal interventricular septum. So we call that the D-shaped septum. We look to see whether it's happening in systole or diastole or both. And here it appears to be present throughout the cardiac cycle. It represents pressure and volume overload, with right ventricular volume overload being present if you have flattening of the interventricular septum in diastole, and if during systole, then pressure overload. Here is an apical four chamber, and again, not a perfect view, but what you can see is you can see that the right ventricle is much larger than the left ventricle. This is the chamber size here, left ventricle, the right ventricle. And you can see that it's greater than the size of the left ventricle, meaning that it's severely dilated. You can see the tricuspid valve is tented and probably poorly coapting. You can see biatrial, severe biatrial enlargement. You can also see that the contractile function of the right ventricle is not fantastic. You can see that the radial contraction is not great, and the longitudinal contraction is not great. But we do have ways of measuring that. but certainly what we look at is the amount of excursion that's occurring in the longitudinal plane, either eyeballing or measuring something called the tricuspid annular systolic plane excursion. And we correlated with what we saw on the short axis, where we didn't think that the radial contraction was particularly great. Really important to think about tricuspid regurgitation. It's quite common as the ventricle dilates that tricuspid regurgitation will occur and gets worse. The septal leaflet is fixed to the interventricular septum, and as the annulus dilates, the anterior and posterior leaflets essentially move outwards with the annulus, resulting in a regurgitant valve that is mainly regurgitant because of the abnormal geometry of the annulus. Severe tricuspid regurgitation increases the amount of work that the ventricle needs to perform, and thus puts the ventricle at greater risk for dysfunction and failure. So we look at tricuspid regurgitation and we try and grade it. Talk a little bit more about that in a second. Finally, we measure the IVC, inferior vena cava. Anything greater than 2.1 centimeters being dilated, less than 50% collapse being associated with a high right atrial pressure, 15 or greater. You can see here this is measured at 2.81. There was no collapse. This is a single shot. So it's a dilated IVC with minimal collapse, high right atrial pressure. Finally, a bit of lung ultrasound. Here we're looking at the left and right lungs. And so remembering that the chest X-ray findings that we demonstrated were symmetrical, and again, the lung findings should be symmetrical. So you've got right posterior lung, left posterior lung, and you can see the presence of B lines in both of those, more than 3 B lines representing pulmonary edema, representing elevated left atrial pressure and high pulmonary capillary wedge pressure. The interstitial disease, if you remember from the chest X-rays, occurred in that middle phase, sort of 19 to 25 pulmonary capillary wedge pressure. So now you can say that the left atrial pressure is probably in that zone. This has been shown to have relatively good correlation with right heart catheter measurements. So bilateral B lines. So just going through the findings, diastolic doming and thickening, rheumatic mitral stenosis, D-shaped septum, which shows us pressure and volume overload, B lines bilaterally, elevated pulmonary capillary wedge pressure, dilated IVC, high right atrial pressure, and a dilated right ventricle with reduced contractile function, so RV dysfunction or failure, and at least moderate TR, which represents RV dilatation or volume overload, possibly even rheumatic disease. When we think about the echo findings, we think about various features and what their meaning are. So, for example, right atrial dilatation, IVC dilatation, coronary sinus dilatation greater than 1 centimeter, suggestive of an elevated right atrial pressure. Systolic interventricular septal flattening, diastolic interventricular septal flattening, right ventricular volume pressure overload, with volume being diastolic flattening and systolic pressure being systolic flattening. Right ventricular hypertrophy, which we haven't covered yet, plus dilatation, usually RV pressure overload in this context. Large tricuspid regurgitation, RV dilatation, high pulmonary pressures, volume state, and rheumatic disease. And then finally, the presence of pericardial effusion often represents impaired lymphatics, prolonged high right atrial pressures, as well as left atrial pressures and end stage pulmonary hypertension. It's really important to make sure that one assesses for mitral regurgitation as well as assessing for aortic regurgitation, because these mixed valvular pathologies can affect your assessment. It's also important to assess for aortic stenosis, but there's limited applicability with basic critical care echocardiography to assess for stenosis, other than the consequences such as LVH and the commissural fusion, which can be seen on 2D. Everything else requires more advanced Doppler techniques. When you do assess for these other valvular lesions, you do need to make sure you're doing it in multiple planes. Remember that one view is no view, and you always need to see orthogonal views with color Doppler and with 2D. All right, I'm just going to revise some of the things that we've been through. So remembering that septal position, depending on where it happens in the cardiac cycle, can represent volume or pressure overload with a D-shaped septum. TAPSE I spoke about in passing. It's a distinct measurement that looks at the tricuspid annular plane systolic excursion. So the longitudinal function of the right heart is demonstrated here. And we look to see how much the annulus moves up and down through systole. This is actually relatively well correlated with RV-PA coupling and with the RV ejection fraction. It's not perfect. None of these simple measurements are, but it's a very useful measurement to learn how to perform. We're going to look for tricuspid regurgitation, and we're going to be looking for a number of things when we're assessing the severity of regurgitation, such as the 2D appearance. We've already talked about tenting, the presence of RV dilatation. That points to the cause of the problem. And we're going to look at flow convergence, vena contracta, the jet area. We're not going to necessarily measure these, but we're going to look at them. We're going to recognize that we're looking at them because they help us grade the severity just using color Doppler. So the flow convergence area is something that you usually see when you've got at least moderate regurgitation. And what you get is you get blood moving into the regurgitant orifice, and it accelerates as it goes. The vena contracta is the narrowest neck of flow, which is not the anatomical neck. It's the narrowest neck of the Doppler signal, and it represents the physiological flow through that orifice. And then the jet area length are something that we also look at, bearing in mind that when you've got severely dilated atrium, they're less useful, and that eccentric jets can lead you to underestimate the severity. And things like a jet area of more than 10 centimeters squared is something that we may look at in terms of determining severity. What TR means, what tricuspid regurgitation means, is usually that you've got high pulmonary pressures, it's a high volume state, plus or minus you've got rheumatic heart disease of the tricuspid valve. This is something that should be assessed for. RV free wall thickness is something that we've touched on. You can see here that the measurement has been taken in the subcostal view with zoom on the right ventricular free wall. You can see here that there's no moderator band or any other chordae included in this measurement, and that the measurement is from not the pericardium, but the beginning of the right ventricular free wall to the blood tissue interface and the cardiac border. Normal is less than 5 millimeters, and anything greater than that represents pulmonary hypertension, essentially a remodeling of a low pressure system in order to accommodate higher pressures. So RV free wall thickness is really important. It needs to be done in a manner where the ultrasound is insinuating a structure that is perpendicular to it, which is why we use the subcostal. Here again, just having a look at the B lines, you can see the pleural line, you can see the B lines. That's an elevated pulmonary capillary wedge pressure. So the evidence is fairly good for this. Making sure that you always count the B lines if you can, or If you have one of the more advanced probes, you can use the AI tools. Just quickly talking about pulmonary artery hypertension, the different groups of pulmonary hypertension. Got pulmonary arterial hypertension, idiopathic types. There's a number of different causes of this. We've got pulmonary hypertension due to left heart disease, pulmonary hypertension due to chronic lung disease, and then CTEP, which is chronic thromboembolic pulmonary hypertension. Precapillary pulmonary hypertension is group 1, group 3, and group 4 with a bit of variation. Importantly, this pulmonary hypertension due to left heart disease, which can be due to LV diastolic function, valvular disease, is a post-capillary problem, sometimes called pulmonary venous hypertension. This is a table that we'll often refer to try and determine what's pre- and post-capillary pulmonary hypertension. In valvular heart disease, it's less useful, particularly rheumatic mitral stenosis, because the RV size rule doesn't necessarily apply. In mitral stenosis, however, you will often get a left atrium that is much larger than the right atrium, up until the point where pulmonary hypertension becomes severe, when they'll often be about the same size. And the interatrial septum is quite a useful tool for assessing what the driver is. But again, once the right heart starts to fail, the interatrial septum can be pushed over to the left because the right atrial pressure may end up being higher. But it's often a good tool to look at, particularly in terms of the early disease, but also in terms of monitoring. Really important to remember in critical care, if you're trying to manage things like pulmonary artery pressures, which is what we're talking about. Now, it's pulmonary artery pressures that are wedge driven, so driven by high left atrial pressure, but you should still think about the basic things such as PO2, pH, CO2 control, how you're ventilating the patient, what level of PEEP you're using, whether you're achieving FRC. Also thinking about what vasopressors and inotropes you use in the volume state, as well as the other important things such as sedation, control of body temperature. Because as I mentioned, increased basal metabolic rate increases the need for transvalvular flow. We have a fixed stenotic lesion. All right, this is where echo becomes useful for the management. You've got a lot of different options for management. You've got diuretics, inotropes, vasopressors. You can try and reduce the PVR using the ventilator. Sometimes we will use pulmonary vasodilators. You've got the introduction of antifailure medications as well as rate control. And then you've got interventional options such as balloon valvuloplasty or surgery. So remembering now that you have reservoir pump conduit functions, and many of the therapies in mitral stenosis that are not interventional are aimed at facilitating a function of the atrium in this fashion. Preload is something that will reduce the amount of volume in the left atrium, so you can alter that through diuretics. The pump function is really important, and we maintain that by rhythm control, so avoidance of atrial fibrillation and mitral stenosis. Then the conduit function, again, is in part rate control. So making sure that through this small fixed orifice, you have enough time for blood to transgress through. And that requires a diastolic time that is not short. So, hemodynamic management. A couple of important things to remember. Severe mitral stenosis can lead to low flow, low gradient aortic stenosis despite a normal LV ejection fraction. And when you're looking for aortic regurgitation, you must distinguish the transmitral flow, which can appear from the ARJ. If you're sure you're just dealing with mitral stenosis, these will be some of the things that you need to consider. Very much you need to manage for the dominant lesion. So you need to make sure that you understand what the most dominant lesion is. Is it mitral stenosis? Is it aortic regurgitation? Is it mitral regurgitation? And this can be quite a difficult thing to do, and usually beyond the realms of basic critical care echocardiography. But if your aortic valve looks okay, the mitral valve looks stenotic, there's not a lot of regurgitation associated with the mitral valve, then that's probably the dominant lesion. The general rule is you have a stenotic valve, you want slow heart rate, slower than usual heart rate, tight as in high afterload, or at least not a low afterload, and regular, so to be in sinus rhythm. So a heart rate of somewhere between 80 and 100 is what we normally aim for. Not a low afterload, so try and avoid vasodilatation. Keep them in sinus rhythm, keep them regular. Regurgent lesions, often the opposite, essentially need a low afterload to reduce regurgitant fraction. And the higher the heart rate, the more full flow. So ideally, you want to look for an inotrope without a heart rate increase, or at least minimize the amount of heart rate increase, whether you use dobutamine or adrenaline. Something I learned when I was recently in the Solomon Islands from Cornelia and Amire, and thank you both, was one of the really important things that you can do using the basic echo and guiding management is assessing the risk of sudden cardiac death with penicillin injections. And in patients with severe rheumatic heart disease, there is a risk of the noxious stimulus of an injection being enough to precipitate cardiovascular collapse, particularly if the right heart is dysfunctional. And in these cases, oral penicillin might be preferred. So management guidance using basic echo, things like collapsing RVC, reduced septal flattening, and reduced TR. These are all going to be goals that you will use monitoring, echocardiography monitoring, to determine. Diuretics, reducing your volume state, this should give you a collapsing RVC if you've done it successfully. No reduced septal flattening will occur as you reduce volume with diuretics. It will also occur if you reduce the PVR by your ventilator, or reduce the PVR by your use of inotropes and pulmonary vasodilators. Reduced TR will come as the RV volume goes down, so reduced pulmonary pressures and improved inotropy and volume reduction. And then finally, behind my picture there is improved TAPSE. And this again, remembering, is a longitudinal measure of function that's relatively useful. It will tell you if the inotrope that you're using is improving the RV function. And as your RV size comes down, as the myocardial fibers align better, as the RV ejection improves, you'll see an improved TAPSE. Finally, we'll just quickly talk about balloon valvuloplasty versus surgery. Neither of these options are frequently available, particularly not urgently in a low resource setting. And so staging and planning for the availability is important before disease has progressed to irreversible. Wilkins score we'll talk about in a second. It's really important to take into account what the surgical pathways are in your country. And in Australia, urgent surgery is feasible and achievable, but often in a low resource setting, planning for surgery needs to take into account the 6-month lead time that will occur and the likely progression of disease over that time, even with optimal therapy. Now, the Wilkins score is somewhat historical, but also still used, and it's an echocardiographic score of valve mobility, valve thickening, valve calcification, and subvalvular disease that can tell you what your chance of having a successful balloon valvuloplasty is, and particularly of avoiding the most feared complication, which is severe valvular insufficiency or severe mitral regurgitation following a balloon. Less than 8 means that you should have a balloon valvuloplasty, or means that balloon valvuloplasty is low risk. Greater than 8, surgery is more likely to be beneficial. Now, in the modern era, this hasn't particularly held true. The biggest things that are actually concerning are the mobility of the anterior leaflet. So obviously the balloon needs to be able to increase that mobility. The calcification of the commissures, which is a risk factor for regurgitation, and any pre-existing regurgitation. Finally, you need to recognise irreversible disease. You can see here that you've got large left atrial thrombus, which extends all the way down there, as well as a severely calcified valve, severe biatrial. Irreversible disease is unfortunately something that's coming to either balloon or so. So in summary, we've talked about valvular assessment. We have talked about assessment of the RV, particularly using TAPSY. Talked about a hemodynamic assessment. We talked about some of the associated problems, particularly that come with left atrial enlargement, mitral stenosis, such as atrial fibrillation, atrial thrombus. Valvular assessment includes the involvement of the valves, so which valves are involved and what is the lesion, regurgitant or stenotic or both, mixed. The severity, and again recognising that this can be done using basic critical care echocardiography, but is best done using advanced echocardiography or comprehensive echo, as well as determining what the dominant lesion is, which again needs to be performed in a comprehensive echocardiography for the most part. Pulmonary hypertension comes in, the assessment of pulmonary hypertension comes into the hemodynamic assessment. We talked a bit about that, as well as the assessment of the left atrial pressure, particularly using lung ultrasound. So there's a lot to be said for the use of basic critical care echocardiography and everything that was taught in the PELS critical care course for assessment about how you manage rheumatic mitral stenosis. Many of these things that I've talked about are a sort of crisis management that are aimed at getting the patient to an intervention, or at least stabilizing them until they're able to survive until they have an intervention. Often patients with this degree of disease have fairly low life expectancies without any intervention. I'd like to thank you for attending, and I'll be online to take any questions. Thanks.